Coffee. And welcome to the Anatomy of Therapy. I'm Dr. John Cybulski here with Bobby Riley. Today I want to talk about how astronauts are going to help you in practice. What? Okay, so let's just start with a little story I heard. This is a real thing. It's a commonly understood thing. I'm also here with Bobby Riley, by the way, who's in Iceland where the sun never sets. Doesn't matter. Astronauts. In space, astronauts, I don't know if you know this, Bobby, but there is no gravity. And so they just float around up there, right? So imagine a couple astronauts up in the outer space just floating around doing tests on plants and, squirting juices out towards each other to eat. We're just going a weird way real fast. But anyways, they're floating around there, and commonly they will lose their sense of what is up and down. Not only where is up and down, but how to move. They need some sort of idea of where they are in space, literally. And if this starts to happen, they'll start to freak out. Their counterparts, their astronaut counterparts, comrades in arms, I don't know what they call them, will know to smack them on the bottom of the heel, basically. Now, they can also do a funny joke and smack them on the top of the head and kind of undo everything. But it is a common practice in the International Space Station when people, at least when they initially get there, to lose their sense of their space and gravity. Proprioception is what we call that in the biz. And when that happens, a partner will then smack them on the bottom of the heel and they will come to, as it were. Fascinating concept about space, but how does that relate to, and how can that make you a master in your practice? Stay tuned. You'll find out. Have you heard of this phenomenon before, Bobby?
No, actually I haven't. Not directly. I read a lot on this stuff. It's something I have not come across personally, but it makes perfect sense. And I've heard of many other weird things involving the adaptive process to being weightless and the amount of blood, like pressure you feel in your head, because, for example, you don't always have a down anymore. So where blood can now pool in your head, you have to get used to that. And it takes like a week for them to stop feeling like they have intense pressure and headaches all the time, because they have to get used to having more pressure in their head. And they don't have the pressure on their heels, obviously, that tells them where things are up and down, because there really isn't one technically.
Right. I've used, I think I remember back when I started the company I work for, people like to use astronauts to describe Wolf's Law, where, when astronauts come back, they are withered and tiny because they don't have stress on their body. And there is a certain amount of stress that our bodies need to do what it does. One of the things, like walking, smacking our feet kind of tells us where we are in space. But I wanted to kind of transition this into rehab initially. There are different positions in rehab. Well, before we get to that, let's put a pin in that. Let me tease you that one towards the end. When people are in pain, certain people call these reference points. And a lot of times, it's kind of back to our episode on hinging, I would imagine it would have some good reference to. But say when someone feels their low back, they are referencing their low back. They sense it as a point of leverage every time they say, roll over in bed, or go from sitting to standing, or try to bend down to touch their toes. Their reference for moving, their leverage, or in your terminology, their hinge point, is kind of in their low back. And so that's just kind of the first place to start, I think, with this concept. Am I wrong? Does it relate to your idea? I know it's not your idea, but you've kind of brought this idea to the forefront of popular culture, I know, but does it relate to hinging?
Well, I think it can, and there is overlap. It's not like they are one and the same necessarily, of course, but typically, if you look at where you're hinging, whether that's in a creased forward shoulder, where the person constantly feels the sensation of tight pecs and a tight trap and things like that. So it's giving them sensory awareness of the things that are constantly working. So that's, if the shoulder's not in that position of being creased and kind of folded forward, then they kind of feel like they're not in their posture, right? Which seems awkward. You pull people in and out of their posture, whatever's natural, and they'll really quickly determine or let you know that things don't feel right, even though it's as right as any other position is. But for them, it's crazy. So that's all sensory.
Absolutely.
Yeah.
I think the half step to where I want to go with this conversation is kinesio tape. And I know there's a lot of people out there that think kinesio tape is absolutely bonkers, but even just to what you said in terms of sensory perception, like at the most basic level, what can I confirm that tape is actually doing besides obviously draining your lymph? It's not doing that. I'm being sarcastic, but it is providing a sensory awareness at a very superficial and cutaneous level where people will feel that tape. And so you can lightly, I want to say very lightly, at a low grade, give people a different sensory perception with that K tape. Now, a lot of times, and this is one of the problems I have when people K tape, they will put it over the area of injury. So like I said, in reference to people with back pain, let's go to shoulder pain. We reference back pain all this stinking time. With shoulder pain, like, I'll see people, they'll have pain in their shoulder, then they'll tape all around that area that also hurts, at least on top of it. So there's still reference to that spot. I try to tape a negative area if I have to tape away from the spot, or next to the neighbor of that area. I'm not taping people to fix them or anything, but that is the light way to kind of go about what it is people are sensing, in relation to that astronaut kind of kitty. Do you guys use tape? Have you seen?
I use it not very often, but I use it. I think I'm the only one in my clinic, but the physios here, of course, use it, but
Sure.
probably more traditionally, according to whatever rock taping or kinesio taping course they took.
Right. I mean, I think the K tape, it is kind of weak to say that you are providing support to somebody with that K tape, unless you're taping it more like an athletic tape. Like when I sprained my ankle in college and I had to get my ankle taped before every game, like my ankle was locked up by that athletic tape in the pre-wrap before, and then it was a nightmare taking it off after the game. But if you're telling me that this K tape is supporting somebody, then this is a straw man, legitimately, that you're holding up. Not even just the rhetorical sense, but like if you think a person is that weak that the K tape is holding them up, I think the safest way to go about it is saying that it is referencing an area. But the next piece I would say is dropping the ball in this conversation. Is the references that we give patients in terms of their posture. Let's just go to that one. So the next thing we say is pull your shoulder blades back. This is the classic postural. I try not to say that, but pull your shoulder blades back. Now the reference for good posture is feeling between your shoulder blades. This tonic rhomboid position is just not sustainable. So even if you could just change the idea of what it is the patient is referencing, and what it is your goal is to reference, to change that reference through treatment, I think is the direction I want to go to. Does that make sense? There's a group of people, we'll just say the PRI people have a list of references. There's literally a list of references. My friends of the DNS, they don't call them references. They're just points, or there's a bunch of different names for them, but there are points in the body. Some people just call them joints, where movement is leveraged through. Even if you just go to your standard CrossFit box, the points are your heels, just like the astronauts. The next point is probably knees out. You may have heard this one. And the next one is probably chest up, which is a little bit vague to me. What are your favorite let's just say bad references that you hear, whether in the gym or the clinic?
Yeah. Well, I'll ask you the same thing and back to you, but I would say if you are generically tossing reference centers at people, that's kind of a bad idea. Um, and I think there's some people that had issues with K-Star and his idea of knees out, and I know K-Star is definitely more nuanced and smart than some people maybe gave his point credit for. I don't think he would be having this low-level conversation of is it knees out or not. I think he would have a bunch of it depends, but being an advocate of that, I think knees out only is necessary if the person has a movement pattern that is not conducive to their squat, that is actually inhibiting their ability to do something and causing a fault of some sort. And when you tell them knees out, it actually corrects the dysfunction and they perform better and they are, look like they're safer from injury and et cetera, et cetera. Well, then knees out is okay. Just like the person who's on their toes and their heels are off the ground as they squat, you might want to give them the cue of, find your heels. Give them the reference of their heels because their reference is the front forefoot or the toes. And you do want to have the heels, but I've seen many times that you say, get your weight on your heels to somebody who's squatting, but you didn't really look at them. Maybe they were leaning a little forward, but now they've lost their toes. And all you've done is just switch the reference center. But you gave them something and you took something away from them. And actually, if you lose your toes, I would, as far as a squat goes, I would say you're even further away from optimal than losing the heels. But that's a different story. Thinking about somebody who wants to broad jump or explode as much as you want, you don't always need the heels, right? But if they're shifted forward, tell them find your heels. But if you're just throwing that at every CrossFitter who comes in, like you have a group of 30 and you're teaching the snatch and you say, okay, get the bar over your head, find your heels, push your knees out. It's so generic. It doesn't help, and in some ways it can harm, I think.
Absolutely. No, absolutely. I mean, yeah, if you're just randomly throwing that out, the other kind of the unknown, you're throwing reference. Let's just go back to the clinical setting. We could stay in the box, but in the clinical setting, even in the gym, you are giving people references, whether you know it or not. Whether you're conscious of it or not, whether you're telling people to sit up, whether you're telling them to put their weight on their heels, their knees out, chest up, you're taping someone's shoulder, you're giving people reference centers, points of leverage. Even in your exercise, if you're recommending, if you're recommending shoes to people based off the previous shoes they have, you're certainly giving them reference centers. So we can talk about it in lifting on your heels, on your toes. I really love the kettlebell idea or powerlift idea of splitting the floor. There was this great quote from this guy, Ron. He says, the floor isn't moving to the left, but it is moving to the left. And so sometimes if you feel your feet on the floor, that simple push your feet away from each other, like there's a piece of paper between your feet. If your feet were on ice, they'd be moving away. You can kind of create a lot more stability versus, spread the floor versus kind of knees out if that tip has kind of worn its welcome. But especially with shoes, if you're, there's so many times a patient will come in with shin splints and, one of the first few questions is, how old are your shoes? You have shin splints and you just switch up to a decent pair of new shoes, you change a new reference. It's the same thing with orthotics, even if they aren't appropriate. And I know people have their favorite orthotics, and some people are very anti-orthotics, go barefoot, walk on rocks, become like a caveman. Really all it's doing is shifting a reference center, shifting a point of balance. So you just need to know that you're doing it, whether you know you're doing it or you're not doing it, if that's fair. Now, to make it a little bit more conscious, to make it a little bit more obvious, some of those reference points, so like spread the floor. In DNS, one of the big points is on the outsides of the heels, on the outside, like kind of the lateral heels. And so spreading the floor, you'd be pushing those heels laterally. Another one is, it's also kind of an L4 reflex, is just above the medial malleolus. So one of those things would be if to spread the floor, not from the, if you even, you could see people move their heels out and they're like, I do feel my heels, but you'll see their medial ankle, that medial malleolus falling in. If you could just get those medial malleoluses away from each other, that will line up a midfoot like nobody's business. And so even for like a lot of simple ankle rehab, if you can kind of have some general pivoting points where this is the exercise, let's say it's just a sprained ankle and we're doing kind of our classic ankle sprain, peroneal inversion, eversion. The reference point that you're giving them is wherever that band is around, say their forefoot or something, and their reference point is now pushing their superior lateral pinky toe outwards. What sort of center of movement is that? Do you know what I mean? If they're moving through that area and they're not feeling their peroneals, you shouldn't be surprised. If, however, you can keep them, their weight on their heel, having them press on that posterior lateral heel, and then pronate, evert their foot, you might get a different reference. So just even going through your classic rehab exercises and giving them one reference point will start to simplify some of these exercises where you may not be getting the muscle to work, if that makes any sense. So that's my kind of problem with any exercise. I think you can make some of these classic, even rotator cuff exercises, the swords, the I's, R's, you know, even if you want to get complicated, your PNF D1s and D2 patterns. If the patient can consciously start to change their reference center for where that movement starts and where it's going, if that makes any sense.
Yeah, and I think these reference centers, as we keep calling them, they end up dictating the way you move. Like, so for example, if we just think of something basic in the gym, like a tricep push down, if your body associates tricep extension with like thoracic extension, so you'll see people who are doing tricep push downs, and the only way that they can push that weight down is to extend their back simultaneously. That is like a reference to which they are referencing something. You know, the way they find their triceps is by extending their back. So they now you have a pattern that's developing where to extend against resistance in the elbow requires extension. So of the spine. And there's many of these types of patterns where, you know, the shoulder blade is not doing what it should do when you press overhead, or you're doing, you know, band pull aparts, and you're not really getting the kind of scapular glenohumeral motion kind of that you should be getting because, I don't know, you're a bench presser and you're used to pinning your shoulder blades down and back. And now you've created a new kind of pattern for how those shoulder blades move. And it creates a certain, we'll call it dysfunction, except for it would be functional for the sport, but not necessarily for the rest of life. And, you know, when you were talking about this, I was thinking, because you mentioned Ron, so you have Ron Ruska, and you also have somebody like Andreo Spina, and both of them in my time learning their material have mentioned similar concepts in different ways. Like, you know, Spina was basically saying, you know, if we were still 5,000 years ago or 20,000 years ago, 50,000 years ago, and our job was to, you know, hunt and gather and run around, and you have basically you're acting like your evolutionary self, then you wouldn't have these issues. And Ron has said similar things more poetically, such as like, you know, if we didn't have flat surfaces, you know, I wouldn't have a job. And in other words, he's saying because everything is flat, you don't get perturbation. Every step is calculated. Your nervous system can find these new patterns to put you in to deal with it, because it's the same thing over and over and over and over. We just sit all the time, or we're at the computer, or we look at our phones, and this is where these patterns drive ourselves. So it's kind of interesting that, you know, you mentioned something like spread the floor, and I'm thinking, yeah, but that's because we created human things like sports and squat, where to squat, you don't have to spread the floor to bend over to like start a fire. You just genuflect and you get some hip flexion, and you get some thoracic flexion and you build a fire. But you're talking about something that was invented because we have sports and people don't know how to generate power from the floor anymore because they can't sense certain things like we've been talking about. So you have to get them to sense it for their sport. And so with those two guys saying, if you just woke up every day and slept with your spouse and then went hunting all day and looking for berries and there was no such things as perfectly planed mall floors, everything was, wilderness, we would only have these acute injuries. You would also see a lot less patternization. You would have people that can reference things and can get in patterns and get out of them. But 2020, this is what me and you, I think we see that walk into our office. We don't necessarily see subacromial impingement. We see patterns. We see reference centers generating the postures that those people are in or the way that they move based on, the fact that we have these evolutionary mismatch with what we're supposed to be doing and kind of what our humanity does now.
Yeah, no, I fully agree, and it just it's almost a little bit more predictable with these flat surfaces, because we just have these go-to patterns. Like, I imagine one of the common patterns today is to reference your phone, and so we've hinted at it a couple times with your eyes. If you're constantly referencing your phone, how is that starting to reflect on the rest of your body, right? The chair that you are constantly sitting in, that it is reflecting your posture, and you are going back to a reference center. If even in like a fatiguing situation, and this is one of my issues in terms of like testing people in clinic, because a lot of times people's injuries aren't like fired up in the moment. And so I can find some orthopedic tests, I can find a hint of a pattern, but a lot of times these patterns don't reveal themselves until they start to fatigue, and then they'll have their kind of go-to reference points in their body. And so this is where kind of listening to the patient and kind of getting a good history kind of come in. But let's just kind of go from a forward standpoint. Let's just say you've got the patients, you know where their pain is in their shoulder, their back, their knee. And now it's time to give them some rehab. We kind of did a little bit with this rehab, but let's maybe a little bit more concretely get into some of these reference centers. The basic one, with the bands, wherever you're giving a person a band, a TheraBand, a monster walk or something like that, you are let's start with a monster walk. This is a very common rehab tool, at least where I'm from. The reference center is now just the outside of their knees, maybe kind of, and, as they kind of walk. If you want to take that to a lower level, that's like a clam, where they put the band around the knees, and now the reference center is at the knees. I am not opposed to a band around the knees whatsoever, as long as you know that is where you are referencing the patient, and if that applies appropriately to that kind of painful pattern. I'm a big fan of starting at the feet, if it is in fact the lower quarter. But let's just talk even overall position. Why would perhaps we start a patient in, laying on their back in a 90-90 position, like doing a bridge, versus perhaps a sideline position on the left, versus perhaps a all four bird dog position? I know a lot of people just have their favorite rehab exercises, but in these various positions, different things are happening. And I'd be interested to understand what you think are happening, in the prone, let's just stick with these: sideline, face up, and then like an all fours position.
Well, again, I think I'll let you go into this further. I would just say, in my mind, I don't really care a lot sometimes about the position. I want it to be more upright, I would say, because I do like that idea of like feeling the ground or being on their feet. But sometimes all those other positions are just different ways for them to finally sense something that you want them to sense. So for example, if you say, well, I need you to feel your posterior hip capsule, can you shift that hip back? And they shift their hip back and they're standing, for example, or standing against the wall. And they say, yeah, I got it. Okay, but your back is extended now. So can I get you to flatten your back against the wall, or, flex your lumbar spine or something like that? And then as soon as they do that, their hip shift goes away. They can't, the pelvis rotates forward or their knee starts to move forward, and they've lost the posterior hip capsule stretch. So no, pull that hip back. Got the hip? Yeah, I got it. And then now their back arches again. So you can see, okay, there's no way I can get them in the position I need to get them in. They gain a reference center, but they lose one, or vice versa. And so what you do is you lateralize or regress, as Charlie Weingroff says, right? And you find a position where you can succeed at the task you're trying to get them to do. So for me, it's not like I prioritize, or I have these levels of what it means. Like at this point in their rehab, they need to be side lying. In this position, they need to be on their back. For me, I guess they're all just ways to get them to sense something, and you want to work it up towards more, you can call functional or related to walking or whatever their activity is, to be fair. I mean, I like what you brought up about, asking good questions and in their injuries and their history too, because I mentioned those guys talking about evolutionary mismatches, but it's also, that can be where these references or these hinge point problems come from, is from old injuries. You've repeatedly stressed or strained your hamstring. And what did that do? Well, you thought it recovered and pain went away, but maybe your whole pelvis now is moving into a different position because you don't have the same input, or either isometric or, just contraction and control from that muscle now because of these strains, that your body is now shifting into a pattern based on pull, like a series of, we call this biotensegrity. I think that was in anatomy trains where they, at least where I read that word, this idea of this tension that's throughout the body. Well, it's just going to pull into positions based on things like that. So, I mean, what do you do? I mean, do you have a certain flow? Can you tell that the person can just start with upright activity right away sometimes, or do you always start kind of easy and work your way up?
Yeah, I mean, a lot of it depends. I would prefer, if I could, to do all my rehab standing. And I've kind of geeked out long enough to where I can see a couple of the cues and perhaps correct things a little bit more intuitively at this point in my career upright. So it's not something I necessarily recommend for everybody. I do think it is the goal, because, by the way, if you have to tell a person you got to get on the ground, you got to lay on your side, you got to put a foam roller down, you got to put your feet on top of that foam roller, you got to put a band around your knees, you got to put a ball between your legs, you got to put a pillow between your head. Now you got to put a little arch under your left side. Now the exercise can begin. They're like, what, dude? That's 14 steps and I haven't even exercised yet. Versus if I go, okay, you need to walk over to your counter, hold on to the sink. I need you to shift your weight back into your heels, predominantly your left. I want you to keep your left butt out, but your left knee in. And if you can keep your weight back into that heel and that hip, and then keep your spine in a good neutral position, maybe a little bit flexed, you should start to feel A, your heel, B, your quad, maybe hamstring, perhaps your glute. If you can feel those three things without engaging your back, I think we're on the right track. And they're way more likely to be able to do that on a consistent basis, because if they start to feel their back, they can walk over to a desk and boom, 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 heel, quad, hip, no back. Cool. And so I just feel like I can get a lot more patients to do that at a higher click. And so the ability for patients to do that is really helpful for me. But if they can't, yes, then like you said, we'll Charlie Weingroff them down to a simpler level. But yeah, I totally agree. But I'm just saying, I do think doctors need to know that if they're asking a patient to get on the ground, let's just start with the sideline. What are you intuitively referencing, whether you know it or not? If they're doing a clam, typically you're targeting the top leg, the top hip. In, say, a left sideline, you're trying to target the right hip. However, now you've referenced that left lateral hip, wherever that's pushing down into the ground. You're also referencing the left lateral shoulder, perhaps the left ribs as well, right? Maybe even the left outside of the knee. So now you're referencing the left side, but trying to engage the right side. And it just gets a little bit more complicated for me, actually, where some people think, getting it lower makes it easier. I think there are more things, and you can get away with it. I'm on your side where I'd like to keep them upright. But I mean, I think the main thing in searching for what the appropriate rehab is where is the gap? What is the patient doing? What should they be doing? And what is the gap that separates those two things? Very simply, they're overextending their back on the left. They're not able to shift their hip back into the left hip or back into the right hip. Once you've kind of established something like that, you can figure out why they're not able to shift their weight into their hip. Are they over-engaging hip flexors? Can they not pull their femur back into their hip? What are they doing? What should they be doing? Where is the space between? That kind of simple formula is my mindset going into these things.
Yeah, I mean, sometimes I would say the things on the floor you can use to your advantage because you're just manipulating the angle of gravity, basically. So for the person who has a hard time keeping their back flat, well, putting them on their back can actually help because now gravity is perpendicular to the spine as opposed to straight down it. So then it can make it easier for them to focus on the thing that you want them to feel, which might be more of their hip or their groin or their heels or whatever it is you're going for. So, and I think this reminded me, we've said this many times, I think, talking this idea of making sure you ask your patients what they feel, because like I thought of this when you mentioned the monster walk, because sometimes they don't say they feel anything like what those, like when you go to the gym and you sit down at the fly machine and it's got the pecs colored red, like this trains the pec, right? Well, according to these textbooks, some of these exercises, well, the clam trains the glute, and then they point to their distal thigh and their low back and their abs when they're doing it. You see, so you if you never ask the question and you just say, I know this exercise retrains this problem, boom, I'm going to give you these exercises, but you don't ever watch them do it. You never ask, so you never see how the strategy that they use to complete the task, and you never ask them what they sense or feel. I don't know. You're just, you're going to fix some of them, but some of them it's not going to go well. And some of them get worse. And you may say, well, it's probably because they did something wrong. And you didn't really realize that your own exercises could make them wrong because they can't complete them without maybe the strategy that's causing their pain in the first place, which is, if they can't handle lumbar extension and they can't do the exercise that you're showing them without hyperextending, well, it doesn't matter if that exercise was meant to be a glute exercise, you're going to have a pissed off low back. That's like you'll see this a lot with bird dogs, and you have, well, I'm giving them core stability because they have back pain. They can't lift that leg or arm without extending to save their life. Then there's no point in doing the bird dog. You have to give them change the angle of gravity, change their sensory awareness of things to where you can give them a chance to succeed. And that's all it is. That's all the reason why there'd be a difference between a side-lying oblique exercise or a standing one or a chop or a Palloff or whatever. All it is because you should be trying to find the one that's most successful for that patient.
Yeah. And back to that complicated quote I mentioned about Ron, where he says the ground isn't pulling to the left, but it is pulling to the left. And back, my floor splitting idea. If you are noticing, to your point about the center of gravity, which I really do love, because if we really think about it, back to the astronauts in the very beginning, hitting on your friend's heel is giving them a sense of where they are. If you are aware of that patient's where they think they are within space, and those muscles are pulling them in a particular direction, like with the Palloff press, so commonly you'll see, one shoulder dipping to one side in a painful position. You'll see this little tilt, right? Your rehab should be to counter that tilt. And it can be very complicated in the three-dimensional space. However, that is kind of like what I feel like you're leading towards. Furthermore, and I totally forgot my next point. It was going to be so good.
Well,
But
I'll just jump on that bandwagon. Like my wife was just doing hip thrusts, the classic Brett Contreras back on the bench and putting the bar across your hips below her pregnant belly and safely. And
good.
and she was saying, and she's had a little bit of problems as of late with left SI. We'll just call it like Fortin's area or SI pain area. But she was basically saying she couldn't feel the left one when she's doing it. She could feel the right one a ton. So, I mean, that's an exercise. Again, if you look at the colored map, it says, okay, the butt is bright red. You're training all these muscles,
Right.
but the patient can't sense it. So that you have to try to solve that problem. And they're referencing something. So she's referencing, maybe it's going to actually irritate her contralateral low back, or I doubt she's going to overload the right glute. I mean, those things are pretty tough, especially the glute max, but something might give if she keeps doing this and she keeps telling me, I can't feel the left one. And it's even worse if you wake up and you have DOMS 2 days later and the right one is extremely sore and the left one feels like it was never trained.
Right.
You got a big problem with this references and the ability to kind of use the musculature in the way that those colored maps are trying to tell you it should be.
No, absolutely. And I think the point I was going to get to was manual therapy. I do think it's doing two things. And we're talking about referencing areas. This kind of goes back to the basic K-star stuff when he talks about lacrosse balls and foam rolls. You can do it clinically in terms of your hand, your elbow, your grasp, and your cupping. That is referencing something. Now, it may be step one, desensitizing perhaps a very tender area that is over-referenced. And so that is one of the ways that manual therapy can be incredibly successful, is desensitizing an area. The second step, hopefully you're trying to sensitize an area, quote unquote, wake up an area. And I'm using big quotes around that just for Adam Meekins specifically, waking up an area. And because if you do loosen up a low back and you do some manual therapy grasping through a hip where, say, someone like your wife doesn't feel that left hip engage, and you do some solid foam rolling, you do some solid lacrosse ball, and you can start to bring some awareness, some attention to that left hip, the body is very intuitive in that sense. And that is one of the reasons why manual therapy can be very successful, specifically for like a situation with your wife there, I think.
Yeah. Yeah. And like with the FRC guys, they do things like PALs and RALs and pails and rails and all that stuff. That's a good way to develop a new, this ability to get a new contraction or reference point, by first, it's basically more specific joint PNF kind of strategy, but that contraction followed by not just a relaxation, but an active contraction in the opposite direction. You also get these end range rhythmic stabilization type of stuff. This like RNT kind of things, anything where you can put them in a position where they can sense that muscle and then train it a ton, So yeah, whether you're looking at old PNF books or more modern courses like FRC, that stuff does kind of hit what we're talking about a little bit. Mm-hmm. Especially if you're not into the PRI DNS route, where it definitely goes deeper in rabbit holes on these topics, right?
Yeah, I'm not going to get into like the triangular sterni reference point,
olivary body
reference point, your left molar reference points. We're not going to talk about that stuff, but there are a lot of reference points through the body, and I would just kind of end on this: you're doing it whether you know it or not. And just try, if you can be a little bit more conscious of the reference points that you are giving to your patients, or your coaches are giving to your athletes, I think you can start to kind of build up an awareness of what it is you're doing and kind of the results that you're getting. Is to first kind of identify what it is you're doing and know that you're doing it. That would be my kind of challenge for this week. What are you referencing, and why are you referencing that?
Yeah, I would just end on exactly that point, but maybe even if that sounds too scary, just start by asking your patients what they feel when they're doing their activity and see if it matches up with what they should be feeling, and see if you can get them to sense it without completely throwing the movement out the window. and keeping somewhat of a correct form.
I love it. What are you feeling, bro? Anyways,
I'm
that's a
feeling.
great way to end. That's a great way to end the podcast. Thank y'all for listening. Follow us on Instagram, YouTube, all the podcasts. Tell your friends. Find out those reference points. Find out what your patients are feeling. Have a great week.
Au revoir.